Vision therapy, Wikipedia article audio. Vision therapy, also known as vision training, is used to improve vision skills such as eye movement control and eye coordination. It involves a series of procedures carried out in both home and office settings, usually under professional supervision by an optometrist or orthoptist. Vision therapy can be prescribed when a comprehensive eye examination indicates that it is an appropriate treatment option. The specific program of therapy is based on the results of standardized tests and the person's signs and symptoms. Programs typically involve eye exercises and the use of lenses, prisms, filters, occluders, specialized instruments, and computer programs. The course of therapy may last weeks to several years, with intermittent monitoring by the eye doctor. Scope: Orthoptic visual therapy. Vision therapy encompasses a wide variety of non-surgical methods which may be divided into several broad categories. Orthoptics is a field pertaining to the evaluation and treatment of patients with disorders of the visual system with an emphasis on binocular vision and eye movements. Commonly practiced by orthoptists, optometrists, behavioral optometrists, pediatric ophthalmologists, and general ophthalmologists, traditional orthoptics addresses problems of eye strain, visually induced headaches, strabismus, diplopia, and visual-related skills required for reading. Orthoptics aims to treat binocular vision disorders such as strabismus and diplopia. Key factors involved include eye movement control, simultaneous focus at far, sustaining focus at far, simultaneous focus at near, sustaining focus at near, simultaneous alignment at far, sustaining alignment at far, simultaneous alignment at near, sustaining alignment at near, central vision and depth awareness. Some of the exercises used are: there is widespread acceptance of orthoptic therapy indications for behavioral visual therapy. Convergence insufficiency is a common binocular vision disorder characterized by asthenopia, eye fatigue, and discomfort. Asthenopia may be aggravated by close work and is thought by some to contribute to reading inefficiency. In 2005, the Convergence Insufficiency Treatment Trial published 2 large, randomized clinical studies examining the efficacy of orthoptic vision therapy in the treatment of symptomatic convergence insufficiency. Although neither study examined reading efficiency or comprehension, both demonstrated that computerized home orthoptic exercises, when combined with weekly in-office vision therapy, were more effective than pencil push-ups for improving the symptoms of asthenopia and the convergence ability of the eyes. The design and results of at least one of these studies has been met with some reservation, questioning the conclusion as to whether intensive office-based treatment programs are truly more efficacious than a properly implemented home-based regimen. The CITT has since published articles validating its research and treatment protocols. Its most recent publication suggested that home-based computer therapy combined with office-based vision therapy is more effective than pencil push-ups or home-based computerized therapy alone for the treatment of symptomatic convergence insufficiency. Behavioral VT aims to treat problems including difficulties of visual attention and concentration, which behavioral optometrists classify as visual information processing weaknesses. These manifest themselves as an inability to sustain focus or to shift focus from one area of space to another. Some assert that poor eye tracking affects reading skills, and that improving tracking can improve reading. Efficacy of behavioral visual therapy. This includes vision therapy for peripheral vision, color perception, gross visual motor, fine visual motor, and visual perception. Some of the exercises involve the use of behavioral vision therapy is practiced primarily by optometrists after doing extra studies in this area. Major optometric organizations, including the American Optometric Association, the American Academy of Optometry, the College of Optometrists in Vision Development, and the Optometric Extension Program, support the assertion that non-strabismic visual therapy does not directly treat learning disorders, but rather addresses underlying visual problems which are claimed to affect learning potential. Behavioral optometry. Major organizations, including the International Orthoptic Association and the American Academy of Ophthalmology, have alternatively so far concluded that there is no current validity for clinically significant improvements in vision with behavioral vision therapy, therefore they do not practice it. Techniques. In 1988, a review of 238 scientific articles was published in the Journal of the American Optometric Association. Widely defined vision therapy as a clinical approach for correcting and ameliorating the effects of eye movement disorders, non-strabismic binocular dysfunctions, focusing disorders, strabismus, amblyopia, nystagmus, and certain visual perceptual disorders, and thereby did not discriminate between orthoptic and behavioral visual therapy. The paper was positive about vision therapy generally. It is evident from the research that there is scientific support for the efficacy of vision therapy in modifying and improving oculomotor, accommodative, and binocular system disorders, as measured by standardized clinical and laboratory testing methods for patients of all ages for whom it is properly undertaken and employed. Conceptual basis and effectiveness. A more recent review concluded less positively that, less robust, but believable, evidence indicates visual training may be useful in developing fine stereoscopic skills and improving visual field remnants after brain damage. As yet there is no clear scientific evidence published in the mainstream literature supporting the use of eye exercises in the remainder of the areas reviewed, and their use therefore remains controversial. In 2006, noted neurologist Oliver Sacks published a case study about Stereo Sue, a woman who had regained her stereo vision, absent for 48 years, after undergoing vision therapy. The article was published in the New Yorker magazine, which is fact-checked but not peer-reviewed. Very few details were given of the exact therapies used, and the article discussed only one case of stereopsis recovery. However, the woman described by Sacks, Susan Berry, a neurobiology professor at Mt. Holyoke College, subsequently published a book, Fixing My Gaze. The book discusses multiple case histories and details the therapy procedures and the science underlying them. History. A systematic review of the literature on the effects of vision therapy on visual field defects published in 2007 concluded that it was unclear to what extent patients benefited from vision restoration therapy, as no study has given a satisfactory answer. The authors concluded that scanning compensatory therapy seemed to provide a more successful rehabilitation, and simpler training techniques. Therefore they recommended SCT until the effects of VRT could be defined. A 2008 review of the literature concluded that there is a continued paucity of controlled trials in the literature to support behavioral optometry approaches. Although there are areas where the available evidence is consistent with claims made by behavioral optometrists, a large majority of behavioral management approaches are not evidence-based, and thus cannot be advocated. Other than for strabismus and convergence insufficiency, the consensus among ophthalmologists, orthoptists, and pediatricians is that non-strabismic visual therapy lacks documented evidence of effectiveness. In 1998, the American Academy of Pediatrics, American Academy of Ophthalmology, and American Association for Pediatric Ophthalmology and Strabismus issued a policy statement regarding the use of vision therapy specifically for the treatment of learning problems and dyslexia. According to the statement, no scientific evidence exists for the efficacy of eye exercises in the remediation of these complex pediatric neurological conditions. More recently, in 2004, the American Academy of Ophthalmology released a position statement asserting that there is no evidence that vision therapy retards the progression of myopia, no evidence that it improves visual function in those with hyperopia or astigmatism, or that it improves vision lost through disease processes. This was also supported by the International Orthoptic Association. The joint statement mentioned above was criticized at the time by Merrill Bowen, a vision therapy enthusiast, for being biased, with the author of a rebuttal concluding the AAP/AAO/AOPO paper contains errors and internal inconsistencies. Through highly selective reference choices, it misrepresents the great body of evidence from the literature that supports a relationship between visual and perceptual problems as they contribute to classroom difficulties. The author also states that the joint statement presents an unsupported opinion by implication that optometrists claim that vision therapy cures the learning problem. A similar criticism could be leveled at the 2004 American Academy of Ophthalmology paper, which implies that vision therapy is claimed to treat vision lost through disease processes. There is a common theme that critics of vision therapy seem to do by placing vision therapy under the same banner with alternative therapies. By implication, the lack of evidence for the alternative therapies is cited as a lack of evidence for vision therapy. No supporting evidence is given that vision therapy is actually used to treat eye disease or vision lost through disease processes. Some optometrists take a slightly different view. In 1999, a joint statement by the American Academy of Optometry, the American Optometric Association, the College of Optometrists and Vision Development and Optometric Extension Program Foundation reported, many visual conditions can be treated effectively with spectacles or contact lenses alone. However, some are most effectively treated with vision therapy. Research has demonstrated that vision therapy can be an effective treatment option for ocular motility problems, non-strabismic binocular disorders, strabismus, amblyopia, accommodative disorders, visual information processing disorders. Research. Practitioners in behavioral optometry practice methods that have been characterized as a complementary alternative medicine practice. A review in 2000 concluded that there were insufficient controlled studies of the approach, and a 2008 review concluded that a large majority of behavioral management approaches are not evidence-based, and thus cannot be advocated. Eye exercises. The consensus among ophthalmologists, orthoptists, and pediatricians is that visual training in non-strabismic behavioral vision therapy lacks documented scientific evidence of effectiveness. Although ophthalmologists and orthoptists believe that exercises can improve binocular vision control, they believe it does not purely improve monocular visual acuity such as that in amblyopia, change a person's refractive error. It is probable that they do not change the accommodative/convergence ratio nor change the amplitude of accommodation to postpone or delay presbyopia. It has been considered that they are unlikely to a person to develop the ability for stereopsis. Nonetheless, recent experimental investigations into dedicated perceptual learning exercises, inspired by Barry's recovery of stereopsis, have shown some promise. Orthoptic vision therapy, also known as orthoptics. Behavioral optometry is a type of complementary and alternative medicine which encompasses a number of unorthodox ideas and practices related to visual processes. In general, behavioral optometrists attempt to improve vision and well-being using eye exercises and lenses in ways which depart from conventional optometry. Therapists aim to treat a broad range of conditions including visual impairments, neurological disorders and learning disabilities. Many of the ideas associated with behavioral optometry lack a clear scientific basis. Research, where it exists, is of low quality. A few of the techniques used align with medical evidence, but most do not. Behavioral vision therapy, or visual integration vision therapy. In a 2008, vision scientist Brendan Barrett published a review of behavioral optometry at the invitation of the UK College of Optometrists. Barrett wrote that behavioral optometry was not a well-defined field but that it was sometimes said to be an extension to optometry, taking a holistic approach. Practitioners of the therapy use techniques outside mainstream optometry to influence the visual process. Barrett discussed these techniques under 10 headings. Other forms. Controversy. History 2. Development. Barrett noted the lack of published controlled trials of the techniques. He found that there are a few areas where the available evidence suggests that the approach might have some value, namely in the treatment of convergence insufficiency, the use of yoked prisms in neurological patients, and in vision rehabilitation after brain disease or injury. But he found that in the other areas where the techniques have been used, the majority, there is no evidence of their value. Near point of convergence exercises, base-out prism reading, stereogram cards, computerized training programs are used to improve fusional vergence, the wearing of convex lenses, the wearing of concave lenses. Cawthorne-Cooksey exercises also employ various eye exercises. However, these are designed to alleviate vestibular disorders, such as dizziness, rather than eye problems. Anti-suppression exercises, this is being less commonly practiced, although occasionally it may be used. Behavioral optometry is largely based on concepts which lack plausibility or which contradict mainstream neurology, and most of the research done has been of poor quality. As with chiropractic, there seems to be a spectrum of scientific legitimacy among practitioners. At one extreme there is some weak evidence in support of the idea that myopia may be affected by eye training. At the other extreme are concepts such as syntonic phototherapy, which proposes that differently colored lights can be used to treat a variety of medical conditions. A review in 2000 concluded that there were insufficient controlled studies of the approach. In 2008, Barrett concluded that the continued absence of rigorous scientific evidence to support behavioral management approaches, and the paucity of controlled trials in particular, represents a major challenge to the credibility of the theory and practice of behavioral optometry. Behavioral optometry has been proposed as being of benefit for children with ADHD and autism. This proposal is based on the idea that since people with these conditions often have abnormal eye movement, correcting this may address the underlying condition. Evidence supporting this approach is however weak. The American Academy of Pediatrics, the American Academy of Ophthalmology and the American Association for Pediatric Ophthalmology and Strabismus have said that learning disabilities are neither caused nor treatable by visual methods. Convergence insufficiency. Patients who experience eye strain, tired eyes, or diplopia while reading or performing other near work, and who have convergence insufficiency may benefit from orthoptic treatment. Patients whose outward drift occurs at distance rather than at near distance are less ideal candidates for treatment. Intermittent exotropia. This is often linked to convergence insufficiency. Behavioral optometry is considered by some optometrists to have its origins in orthoptic vision therapy. However, vision therapy is differentiated between strabismic/orthoptic vision therapy and non-strabismic vision therapy. A.M. Skeffington was an American optometrist known to some as the father of behavioral optometry. Skeffington has been credited as CEO founding the optometric extension program with E.B. Alexander in 1928. A review in 2000 concluded that there were insufficient controlled studies of the approach, and a 2008 review concluded that a large majority of behavioral management approaches are not evidence-based, and thus cannot be advocated. The eye exercises used in vision therapy can generally be divided into two groups: those employed for strabismic outcomes and those employed for non-strabismic outcomes, to improve eye health. Some of the exercises used are: the eye exercises used in behavioral vision therapy, also known as developmental optometry, is practiced primarily by behavioral optometrists. Behavioral vision therapy aims to treat problems including difficulties of visual attention and concentration, which may manifest themselves as an inability to sustain focus or to shift focus from one area of space to another. Some of the exercises used are: ophthalmologists and orthoptists do not endorse these exercises as having clinically significant validity for improvements in vision. Usually they see these perceptual motor activities being in the sphere of either speech therapy or occupational therapy. Fusional amplitude and relative fusional amplitude training. Certain do-it-yourself eye exercises are claimed by some to improve visual acuity by reducing or eliminating refractive errors. Such claims rely mainly on anecdotal evidence, and are not generally endorsed by orthoptists, ophthalmologists, or optometrists. Chinese school children always do eye exercises twice per day during school, which are compulsory. They are also part of other forms categories as they are also do-it-yourself exercises, although quite a few scientists say that they actually harm the children's eyes. The German optician Hans Joachim Haas developed a method to correct an alleged misalignment. His method, called the MKH method, is not recognized as an evidence-based approach. Some physicians are skeptical about the efficacy of vision therapy, stating that it lacks data and is mostly anecdotal. In 2009, the American Academy of Pediatrics along with the American Academy of Ophthalmology essentially declared war on developmental optometry, as Judith Warner wrote in a New York Times article. Even within the field of optometry, the UK College of Optometrists noted the continued absence of rigorous scientific evidence to support behavioral management approaches in the Second College of Optometrists report. The American Academy of Pediatrics is also critical of behavioral optometry. In 2009 it reviewed 35 years of the literature in support of vision therapy and issued a statement. In conjunction with other ophthalmological associations, condemning the therapy and its contention that it could help with learning disabilities. Visual problems, it claimed, are not the basis for learning disabilities. It issued a stern warning about the seductions of treatments that sound convincing but aren't based on science, ineffective, controversial methods of treatment such as vision therapy may give parents and teachers a false sense of security that a child's learning difficulties are being addressed, may waste family and/or school resources and may delay proper instruction or remediation. The website by the American Association for Pediatric Ophthalmology and Strabismus states, behavioral vision therapy is considered to be scientifically unproven and there is no evidence that vision therapy delays the progression or leads to correction of myopia. Various forms of visual therapy have been used for centuries. The concept of vision therapy was introduced in the late 19th century for the non-surgical treatment of strabismus. This early and traditional form of vision therapy was the foundation of what is now known as orthoptics. In the first half of the 20th century, orthoptists, working with ophthalmologists, introduced a variety of training techniques mainly designed to improve binocular function. In the second half of the 20th century, vision therapy began to be used by optometrists and paramedical personnel to treat conditions ranging from uncomfortable vision to poor reading and academic performance. It has also been used specifically to improve eyesight, and even to improve athletic performance. At the beginning of the 21st century, most vision therapy is done by optometrists, while traditional orthoptics continues to be practiced by orthoptists and ophthalmologists. Based on assessments of claims and studies of published data, ophthalmologists claim that, except for near-point of convergence exercises, vision therapy lacks documented evidence of effectiveness. Marsden balls, rotation trainers, syntonics, balance board/beams, saccadic fixators, directional sequencers. Near point of convergence training, or the ability for both eyes to focus on a single point in space, base-out prism reading, stereogram cards, computerized training programs are used to improve fusional vergence, the wearing of convex lenses, the wearing of concave lenses. Cawthorne-Cooksey exercises also employ various eye exercises, however, these are designed to alleviate vestibular disorders, such as dizziness, rather than eye problems. Anti-suppression exercises, this is no longer commonly practiced, although occasionally it may be used. Marsden balls, rotation trainers, syntonics, balance board/beams, saccadic fixators, directional sequencers. Designed to alleviate convergence insufficiency. The CITT study was a randomized, double-blind multi-center trial indicates that orthoptic vision therapy is an effective method of treatment of convergence insufficiency. Both optometry and ophthalmology were co-authors of this study, designed to alleviate intermittent exotropia or other less common forms of strabismus.